Good evening, everyone. Welcome to the BSLM webinar series for July. We've got a couple of excellent presentations for you this evening, but before we start, just a couple of bits of housekeeping. So please say hello in the chat function at the bottom below. For those of you that have attended a number of these sessions, you'll be very familiar with it. But for those that haven't, please say hello. But please also use the Q&A function only for questions. We may well miss your questions if you pop them in the chat. So Q&A for the questions, please. We have two recordings this evening, and we're going to play them back to back. But both presenters will join for a live Q&A at the end of the session. So we're thankful for them for being able to do that. Our first presenter is Dr. Hamish Foster, and he'll be talking about the challenges of reducing risk and severity of cardiovascular disease in socio-economically deprived communities. And the second presenter is Dr. Hugh Bethell, who will be talking about exercise and health. First presenter Hugh is a general practitioner and a clinical research fellow based in the General Practice and Primary Care Research Group at the University of Glasgow, and is interested in health, social inequalities, lifestyle behaviours, obesity, physical activity, and mixed methods. So we're going to go straight in with the first presentation, if we could, with Dr. Hamish Foster.
Hi, my name is Hamish Foster. I'm a GP based in Glasgow, and I'm also a research fellow at the University of Glasgow, where I've just completed my PhD that focused on health behaviours and their interaction with socioeconomic status. And this is a presentation that I hope will be of interest to people at the British Society of Lifestyle Medicine. Just some acknowledgements briefly for my academic colleagues as well as clinical colleagues. And to lay out the structure of this talk, I'll briefly mention or describe what deprivation is and what are the challenges that deprivation bring to lifestyle or health behaviours, which I'm sure many of you will already be aware. I'll explain a bit about some of the key findings and studies within my PhD, and then some conclusions that are relevant to clinicians. Just a kind of warning that this presentation has a primary care and social focus. I'm a GP, and it's hard not to have a social, even political focus when you're interested in socioeconomic deprivation and health behaviours. And although the challenges are great that I will lay out that deprivation brings to lifestyle, I think there is still room for optimism. So what is deprivation? Well, this is a map of the Scottish Index of Multiple Deprivation, showing the central belt in Scotland, with areas in red representing areas of high deprivation and blue as more affluent areas. And you can see Glasgow on the west or on the left side of the map there, shining in red, unfortunately, compared with, say, Edinburgh and the east there, which with many more blue areas. But how do we measure it? Well, there are lots of different ways. This one, Scottish Index of Multiple Deprivation, has a number of different domains, and different factors go into those domains to make up a score, if you like, with various weightings for each of the factors. And essentially, you can think of deprivation as a measure of what people are lacking, whether that be clothing, housing, education, that could be expected or are customary for the society in which they live. And that also includes, I would like to argue, lifestyle. So people are, or health behaviours, so people are lacking in ways of living that also incorporate health behaviours. They directly link to health, or some of them are kind of health measures. You can see their mortality ratios, but this is a newspaper clipping that I use to remind myself that socioeconomic factors can directly, of course, affect health. And this was a case where I think mold or housing situation was put on a death certificate for this poor wee boy. But what does deprivation mean for health behaviours? Well, there are a number of challenges that socioeconomic circumstances bring directly to lifestyle. And here are some of them, and I'll go through this list in a bit more detail. So multimorbidity, we know that if you have certain health problems, that can make certain ways of living more challenging. So if you look at this area that I've circled on this graph, you can see that the age at which 30% of the population have 3 or more long-term conditions is much earlier, is a much younger age for those in more deprived areas compared with those from more affluent areas. So that's the first challenge. And not only are the health problems more numerous, but they're more complex. So this graph shows from a study of GP practices in Scotland. The blue line shows the standardized mortality rate. And so you can see that with increasing level of deprivation, the mortality rate goes up, but also the physical and mental comorbidity goes up. So sort of complex multimorbidity, and that adds another challenge when trying to support people with lifestyle and health behaviors, that they have complex multimorbidity. They have both physical and mental comorbidities, which bring challenges. And also the level of funding, represented by the black line, is relatively flat. So the level of funding to GP practices in most deprived areas is similar to that for more affluent practices. And the green line is just the consultation rate, again, relatively flat. But obviously you can see the need in more deprived areas greatly outstripping the funding and consultation rate, the sort of health provision. And this is where the flag for a group called GPs at the Deep End, if you've heard of it, this is where it comes from. If you flip that graph around, you get a kind of swimming pool where patients, members of the public, and GPs or practice nurses are swimming in the deep end, in the depths of multimorbidity, complex multimorbidity, and the surface of the water is a kind of this flat level of funding. So that's their symbol or their flag to rally under GPs at the deep end. And we know that there's reduced access to healthcare. This is an interesting study from colleagues at the University of Glasgow that looked at the number of long-term conditions and the risk of missing an appointment. And we can see that people with more long-term conditions have a higher risk of missing an appointment. And this, in the same study, shows that those who miss more appointments have a higher all-cause mortality, sort of highlighting how missing appointments is actually a risk factor for poor health. In more deprived areas, there's more evidence or a higher prevalence of childhood maltreatment, which complicates giving advice and supporting people with healthy ways of living. So this graph on the left from colleagues again at Glasgow looked at the number of long-term conditions and the percentage with different types of childhood maltreatment. And so people with more long-term conditions had a higher risk or were more likely to report different types of childhood maltreatment. Again, highlighting the complexity of the multimorbidity in more deprived areas. This infographic on the bottom right of the slide is from the Scottish Health Survey, which shows that adverse childhood experiences follow a socioeconomic gradient, with more deprived areas reporting more adverse childhood experiences. And there are many other complexities I've highlighted there, such as the benefit system, the justice system, housing, all different in more deprived areas, all adding challenges to healthy ways of living. This is another specific issue. So enablement, patient enablement is a measure of the impact of a clinical encounter on the patient's ability to understand and cope with their health behavior. So in other words, their ability to follow advice. That includes health behavior or lifestyle advice. And essentially what these two graphs show is that although consultation durations tend to be longer in more deprived areas and the GPs or the practitioners tend to be more stressed, the level of enablement felt by patients to deal with their health problems is lower in more deprived areas. So they feel less able to make healthy change, for example. We know that there's a higher prevalence of unhealthy lifestyle factors in more deprived areas, and there's a higher clustering. So not only do they have more smoking, alcohol, physical activity, higher rates of unhealthy lifestyle factors, but there's higher rates of complex combinations of them, including newer ones such as the lack of social participation, poorer sleep, added salt to food. There are a number of them. And with increasing number of unhealthy lifestyle factors, you get a higher rate of mortality. And this is a study I was involved in where we provided some evidence that there's actually a disproportional impact of unhealthy lifestyle factors in areas of deprivation. So if you look at the pink bars, that represents people from this study of around 500,000 adults across the UK. That represents those participants that had an unhealthy lifestyle as measured by these 9 lifestyle factors. And it's split by quintile of deprivation. So the bars on the right, more deprived, the bars on the left, less deprived or more affluent. And you can see that although people with represented by the pink bars had similarly unhealthy lifestyles, they had much higher risk of, in this case, CVD mortality. So there's an interaction, we can say, between deprivation and lifestyle. So there seems to be a disproportionate effect of having an unhealthy lifestyle in more deprived areas. Not only that, these 2 graphics show that there's, on the left, it shows a map of Glasgow, that there's a higher density of alcohol, fast food, tobacco, gambling outlets in more deprived areas compared with affluent ones. And the one on the right is a map of Liverpool showing the density of unhealthy advertising is higher in more deprived areas. So signaling the environment is much more challenging for having healthy ways of living in more deprived areas. And not only that, this table on the left is evidence from the Scottish Household Survey showing that access to green, blue and open space is less, and people are less satisfied with their local green space in more deprived areas compared with more affluent ones. And the graph on the right shows the percentage of your disposable income that you need to spend in order to meet healthy eating guidelines. And there's nearly 50% of your income you need to spend if you're from a more deprived or a lower income quintile. So really challenging to meet healthy eating guidelines in more deprived areas. People don't tend to see themselves at risk. So this is from the picture on the left is from a study looking at CVD screening. People tend to turn up less from more deprived areas to be screened. However, if they do turn up to be screened, then they're at higher risk. And these quotes on the right highlighting how there's perhaps more fatalism or lower expectations for health. You know, people who work in more deprived areas can be accustomed to patients in their 50s or 60s coming in to see them talking about how that they know that they're getting on, they're getting old, and it's not surprising because they're 50 or 60 because their parents may have been unwell and died at that age too. So maybe lower expectations for health in more deprived areas. There's lower rates of health literacy in more deprived areas, making understanding and digesting information around health behaviours and lifestyle more challenging. There's perhaps more language barriers with higher rates of Black and minority ethnic groups in more deprived areas. And there's also differences in terms of CVD risk, so linked to lifestyle by ethnicity. So an additional challenge there as well in more deprived areas. So in summary, there are numerous challenges, more health problems, more complicated combinations of health problems, less time, fewer resources, harder to engage for patients and clinicians. There are more unhealthy lifestyle factors or unhealthy behaviours contributing to their risk. The environment in which they live is less conducive to healthy change. They have less power to make healthy change. There's a reduced perception that there's even a problem in the first place or opportunities for healthy change. There's lower health literacy or ability to use advice and resources, higher rates of language barriers, and less hope perhaps or less future planning with these lower expectations for health outcomes. So there are a lot of challenges, and I wanted to explore some of these more in my PhD, particularly this disproportionate harm that I mentioned being associated with unhealthy lifestyle factors. So the first thing I wanted to do was to look at if there were more studies that showed similar things. So we did a systematic review looking at how socioeconomic deprivation might influence the link between unhealthy lifestyle and health outcomes like mortality. And essentially, we found that not many studies look at this. and of the ones that do, there's probably what we call an additive effect, where the effect of, slightly more than an additive effect. So the effect of socioeconomic deprivation plus the effect of an unhealthy lifestyle seem to add together to be more than the sum of their individual parts. So there is an indication that there is an additive effect, and that we should be targeting both unhealthy lifestyle and socioeconomic status at the same time or similarly. The next part of my PhD was looking at social connection, because social participation can be considered a sort of new lifestyle factor, and we wanted to create a lifestyle score, with social participation being one of the lifestyle factors included in that score. And in order to know which aspects of social participation to include in our score, we first needed to examine some of the links between different types of social connection and mortality outcomes. So this graph here shows one of our main findings from this paper that we produced on social connection, looking at different aspects of social connection, both subjective and objective ones. Subjective ones being those things that you feel internally, like feelings of loneliness, whereas objective ones being things that are more amenable to counting, such as whether or not people live alone, whether they participate in weekly group activity or see friends and family often. And in short, we found that each of them are independently linked with mortality. However, there were some that had higher risks, were associated with higher risk of mortality than others, such as never having friends and family visits or living alone. However, when we looked at combinations of the two, so both having one subjective and one objective measure of social disconnection, was associated with even higher risks of mortality. And so we took that information and we used it to help create a new lifestyle score. Again, using a big data set, we looked at these 11 different lifestyle factors: smoking, alcohol, physical activity, TV viewing, sleep duration, a few dietary factors, and social participation levels, based on that previous social connection work. And we looked at each of these lifestyle factors individually and their link with all-cause mortality. And you can see that different lifestyle factors have different strengths of association with mortality, with smoking having the highest one. So to create our lifestyle score, we wanted to create a weighted lifestyle score where each lifestyle factor is given a sort of relative importance or a higher score if it has a stronger association with mortality. So smoking was given 14 points. All the others, bar some dietary factors, were given 2 points, and things like oily fish, red meat, processed meat, added salt, given 1 point, to make a total of 30. And another part of our PhD, as well as creating that lifestyle score, I did some qualitative work where we did 4 focus groups with members of the public and 18 interviews with different kind of key stakeholder professionals, including community links workers, practice nurses, GPs, some public health consultants and policymakers, trying to understand their perceptions of what unhealthy lifestyle factors mean in the context of socioeconomic deprivation. And some of our key findings were an evolving complexity of health behaviours, a detailed appreciation of how poverty determines lifestyle, and how there's a spectrum of agency that's in tension with structure, and I can explain a bit more what I mean there. So in terms of an evolving complexity, I'm showing here that there are numerous lifestyle factors, and the number of lifestyle factors that clinicians and individuals from the public have been considering that might impact their health has been growing over time. That really came out in the focus groups. So for example, new ones like time spent immersed in nature or in proximity to blue or green space, attending health appointments, gambling, social media use. These are all kind of new health behaviors. With increasing numbers of health behaviors, there's increasing complexity of their interactions. So different health behaviors impacting on each other, and into a really complex picture around what it means to try and make healthy change. Just another key finding was around this spectrum of agency. So all the participants felt that there was always some level of agency, even in really difficult socioeconomic circumstances, to make healthy choices. However, it was under some tension with structure. So structure having, and by structure I mean social structure, so things like your financial situation, your neighborhood, your social norms, all of these things impacting on how much agency was assigned to people, or what people perceived as people having agency. And that meant for clinicians there was this balancing act where, although they were very aware of people's difficult socioeconomic circumstances, they still wanted to try and afford them some agency. In fact, they felt they had a duty to cultivate any agency residing in people, to encourage them and motivate them. They felt that they had this duty to not to encourage hope, to instill hope in people that some healthy lifestyle changes were possible. So in the next steps, just now I finished my PhD, just to if it's of interest, and a kind of a shameless plug, because I want to create an app that's based on this weighted lifestyle score we've made, and we want that to provide personalized information that links people to local resources around lifestyle and health behaviors. So a bit like a digital version of a community links worker. I'm sorry, I hope you know what a links worker is. It's like a community navigator that points people, that can be really helpful in pointing people to local resources, including mental health resources, which we know are really key around lifestyle. So I'm doing that. So if you want to get involved in that, I'm doing some pilot stakeholder work. So I'd be very happy if people contacted me to get in touch about being involved with that. In terms of relevance to clinicians, and to sum up this this presentation, key ones I would say from the qualitative work: go easy but don't give up, because yes, we want to instill some hope in people that healthy lifestyles are possible despite difficult circumstances, but and we want to raise expectations. However, we need to be realistic, and we should also be thinking about changing the wider environment and using our voice as advocates for wider social change. I have more slides, but I think that is me over my time. I'd be very happy if anyone would like to get in touch.
Thank you, Hamish. That was great. And just a reminder, we'll come to Hamish for questions at the end of Hugh's presentation. So let me introduce Dr. Hugh Bethell. He trained at Cambridge and Guy's Hospital, qualifying in 1966, entered general practice in Alton in 1974, retiring in 2002. In 1976, he also opened the Basingstoke and Alton Cardiac Rehabilitation Centre and was medical director there until 2002. He chaired the Coronary Prevention Group Secondary Prevention and Rehabilitation Committee from 1988, and in 1992 helped to found the British Association for Cardiac Rehabilitation and elected as its first president. And he's currently directing a primary prevention clinic, the Stay Well programme, at the Cardiac Rehabilitation Centre. So if we could have Hugh's presentation, please.
For allowing me to give you this talk. It is my intention to persuade you that the most important lifestyle change you can make for your patients is to help them to become more physically active. As this slide illustrates, exercise increases physical fitness, which increases health. The power of exercise was nicely quoted by the Chief Medical Officer in 2009. He said the benefits of regular physical activity on health, longevity and well-being easily surpass the effectiveness of any drugs or other medical treatment. So why is this so? Well, it is because exercise is so effective in both the prevention and treatment of all the degenerative non-communicable diseases of later life: obesity, high blood pressure, diabetes, heart disease, stroke, arthritis, mental illness, osteoporosis, Parkinson's disease, cancer, various cancers, and dementia. But perhaps more important than all of those, and a sort of summation of them all, is frailty and ultimately premature death. I'll go through some of these conditions. This is the Venus of Willendorf, 27,000 years old. It's the oldest known representation of the human form, and I present it to show you that obesity is nothing new about it. And of course, it has all the ill effects we know about: high blood pressure, diabetes, heart disease, shortness of breath, cancers, etc., and very expensive for the nation as a whole. And its ill effects are nicely demonstrated by the increase in premature death seen with increasing body mass index. The y-axis here shows the risk of dying over the next 5 years compared with people of normal weight, with increasing BMI along the x-axis, so that by the time you reach the obese range, you have an increased risk of dying between 45 and 96%. But once you're in the morbidly obese range, it's 276%. So that's 2.5 more likely to die. And why is obesity increasing at the rate it is? Well, it could be more food, more fizzy drinks, widespread use by the food industry of high fructose corn syrup, increasing portion size, etc. We live in an obesogenic environment, but also less exercise. What about less occupational exercise? We have to do much less to earn our daily crust. Motorised transport gets us about instead of Shanks's pony. We've been selling off school playing fields, and our involvement in sport has changed largely from participation to spectatorship. And one of the telling points that makes less exercise seem to be as important or more important than eating more is that the overall calorie intake has been falling since 1970 in this country. Exercise for obesity, well, firstly, to lose weight requires much more exercise than most people believe. At least double the exercise recommendation of the Department of Health. And this is because food is a remarkably efficient fuel. So just dieting in the end is usually a more efficient way of losing weight than just exercise. But if you're going to be successful in losing weight, you almost certainly need to do both. High blood pressure, another risk factor, and it is a risk factor for atheroma, for heart disease, for stroke, for kidney disease. And its causes: obesity, too much salt, too much alcohol, stress, and again, not enough exercise is an important factor. If you look at the figures, regular exercise have about 1/3 the risk of developing hypertension. And also there is an inverse relationship between CRF, that's cardiorespiratory fitness, and blood pressure. And if physical exercise is used as a tool to reduce blood pressure, it is prescribed properly, it is about as effective as medication in reducing blood pressure. Coronary heart disease. Coronary heart disease is the commonest cause of death in the UK for men still, and only recently been overtaken by dementia for women. And it kills 180,000 people a year in this country. That's equivalent to a jumbo jet crashing every day. And exercise is very important in both the prevention and the management of coronary disease. The use of exercise in the prevention of CHD was first mooted and tested by Professor Jerry Morris at the London School of Hygiene, and he conducted the London busman study, and he believed that the bus drivers would prove to have a greater risk of heart disease than the conductors, and indeed it was so. The drivers having about a 50% higher risk of developing coronary disease than the bus conductors who were running up and downstairs and keeping physically fit. But exercise is also very important in the management of coronary disease. When I first qualified, if you had a heart attack, you were in hospital for 4 to 6 weeks, most of that time spent on bed rest, and when you were sent home, you were advised to do very little, eke out your miserable existence in a sedentary lifestyle. Well, that changed in the 1950s and 60s with the development of cardiac or coronary rehabilitation, first proposed and designed by Herman Hellerstein in the States. And interesting quote from one of his papers, he wondered whether it is possible to interest habitually sedentary, lazy, hypokinetic, sloppy, endomesomorphic overweight males to adhere to a program of enhanced physical activity. He clearly held his coronary patients in high esteem. When I was a hospital doctor, I worked in the cardiac department at the Charing Cross Hospital, and that was back in the late 60s. And my consultant, Dr. Peter Nixon, was a proponent of cardiac rehabilitation. He got his patients out of bed, sent them off to the local gymnasium, and his colleagues thought he was daft, but time has proved him right. I gave up working in hospitals in the early 1970s, and I moved to Alton, and there I found the Alton Sports Centre, a brand new facility, and I went to talk to the manager and asked if I could bring some coronary patients in to see if we could get them fitter. And I thought he'd chuck me out, but he didn't. He accepted that what I had to offer was worth trying, and we set up a program of exercise, starting people about a month after their heart attacks with a circuit training exercise program. And we did this for a couple of years and then offered it to the Basingstoke District Hospital. And since 1978, we have been the first port of call for people discharged from the coronary care unit at Basingstoke. We've worked out of the sports centre until the early 90s, when really they were running out of space, so we had to build our new centre to accommodate what we wanted to do and provide a proper service. We did a randomized controlled trial of cardiac rehabilitation and were able to demonstrate greatly increased fitness and reduced symptomatology amongst the people who've been through our program compared to the control group. But we didn't have a large enough group to demonstrate an improvement in long-term prognosis. But our figures were used in the meta-analyses, which were able to show that those who go through a cardiac rehabilitation program after a heart attack have a 25% lower mortality at 5 years than those who have not been through such a treatment. Type 2 diabetes is a massively increasing problem in this country. Risk factors we know: obesity, lack of exercise, and of course for a small percentage of sufferers it's family history that's the guilty party. And the rate of diabetes has increased hugely over the past 40 or 50 years. From when I was first a doctor, about 1% of the population had type 2 diabetes. It's now about 6% and still rising. The ill effects are what really matters: the heart disease, the stroke, the amputations, the kidney disease, the blindness, the neuralgia, the dementia. It's a really horrible disease, and it is preventable and treatable by exercise. This was demonstrated neatly by Professor Lean in Newcastle, who a few years ago took a cohort of newly diagnosed type 2 diabetics and put them through a really intensive weight losing program of diet and exercise. And this histogram shows you the results. The charts of achieving remission on the y-axis compared with the amount of weight lost: 5 kilos, 5 to 10, 10 to 15, or more than 15 kilos. And by the time you reach the group who lost more than 15 kilograms, that's a couple of stone, 86% were in remission. I think that's a very important finding, and I don't think it's sufficiently emphasized to patients that if they lose weight, they can lose their diabetes and all the complications and inconveniences that go with it. Stroke is another condition in which physical fitness is important. It's caused by high blood pressure, by obesity, and by smoking, but also by lack of exercise. And this is neatly demonstrated by this histogram, which shows the stroke event rate on the y-axis against physical fitness on the left, on the x-axis. And the high physical fitness group have about 1/5 the risk of having a stroke of those in the low fitness group. Physical fitness and regular exercise are powerful preventers of cerebrovascular accidents. Other groups of individuals and patients who benefit from exercise, mental health is one of these groups. Up to about 17% of us suffer from current depression or anxiety, but regular exercise reduces the incidence of depression by 25%, and regular exercise suffer about half as many bad days as non-exercisers. Exercise, when used as a treatment, is about as effective as antidepressants or CBT. Dementia, another increasing group, nearly 1 million sufferers in the UK, projected to rise to about 2 million by 2050, and high levels of physical fitness delays the onset of dementia by about 10 years. Osteoporosis, some more statistics, 3 million sufferers in the UK. There are 300,000 fragility fractures annually in this country, and hip fractures occupy over 1 million hospital bed days per annum. But regular exercise have about 1/3 the risk of a hip fracture, and regular weight-bearing exercise can delay or even reverse osteoporosis. But the most important of all the conditions that I've been talking about is also a summation of them all, and that is frailty. This is the rather verbose definition of frailty, the clinically recognizable state of increased vulnerability, etc., etc. But actually it's neatly summarized by saying it's being old and feeble, and it's caused by loss of muscle mass, sarcopenia, loss of muscle mass and strength. We all gradually lose muscle mass and strength as the years go by. But if we take plenty of exercise, we can delay the rate at which we can slow down the rate at which this develops. So frailty and sarcopenia result from all those conditions which reduce the amount of exercise we're likely to take, and they in their turn are all likely to be promoted by having taken insufficient exercise anyway. So obesity, diabetes, heart disease, stroke, cancer, lung disease, joint disease and dementia, they're all causes of frailty, and they all carry this one characteristic: low levels of physical fitness. You need a certain degree of physical fitness to be able to get yourself out of bed in the morning, to be able to get yourself dressed or get out of your chair and get a cup of tea if you want one, rather than needing a carer to do it for you. You can look at it in this way. This is a graph of functional ability, which is closely related, of course, to physical fitness, compared to increasing age. And this is your average individual who will increase their functional ability through childhood to peak levels in their early 20s, then get a sitting down job, and after that the rate of decline is inevitable. We all get less functionally able as we get older, but if we take plenty of exercise, that rate of decline is much more gradual than if we take no exercise at all. And that becomes more important too when you consider this line, the functional ability needed for independent living. If you are unfit, you're going to hit this line in your 80s and 90s. If you're fit, you're never going to hit it. And this is exaggerated if when you develop an intercurrent illness or fall over and break your hip or something, you have to go into hospital. There is a sharp decline in physical fitness. Hospitals are good places for sedentary existence and decreasing your physical fitness level and increasing your likelihood of becoming frail. You can look at it also in terms of health span and lifespan. Health span, this little pale blue area, is your length of life in which you are able to do what you want to, you're physically active and well. Lifespan is the total duration of your life. This mauve area here is sometimes referred to as terminal morbidity. And for the average individual in this country now, it's between 15 and 20% of your lifespan. If you take individuals who take a lot of exercise, their lifespan is increased, but their health span is increased disproportionately, so that this little area at the end of life, the terminal morbidity, this period of time is shortened. You live well until you're nearly time to die, and then you die quickly. That's what we all want out of life. The consequences of frailty, well, debility, dependency, the increased risk of falls, the need for regular care, the increased risk of needing to go to hospital, delayed discharge, and all of this leading to those queues of ambulances waiting outside A&E departments. Need for residential care, enormous social and financial costs, and increased risk of COVID. Most of the people who died during the pandemic were elderly and frail. And the cry went out, don't kill Granny. And I think the cry should have said, send her to the gym. It is exercise that both prevents frailty, but if you become frail, it's not too old to be taking up an exercise to try and increase your physical fitness and your ability to look after yourself. Finally, there's longevity. I have illustrated this with a histogram showing the effect of physical fitness on age-adjusted death rate on the y-axis. This group is the low fitness, here is the mid fitness, and here's the high fitness group. And the high fitness group, really about a third of the rate of death rate of the low fitness group. How much exercise? Well, this is a graph showing the benefits of increasing levels of physical exercise expressed in terms of minutes of exercise per week. And the more exercise you take, the more benefit you get. But the steepest part of the curve, curious enough, is at the very lowest level. So if you go from doing nothing to doing a bit, you're probably doing the most you could expect to do. And exercise intensity is important. If your exercise intensity is relatively low, as you say, go for moderate intensive exercise, then your increase in benefits is relatively lower than if you take high intensity exercise, the dotted blue line, the red line being an average of the two. How much should we do then? Well, this is the Department of Health guidelines, which you'll know that is 150 minutes of moderate intensity aerobic activity each week and muscle strengthening activity on 2 or more days a week. This is relatively modest amount of exercise to take, but the powers that be that recommend it recognize the fact that if you give people too much to do, they won't do anything at all. So this is a compromise. An interesting study done by the Health Service for England back in 2008 asked a cohort of individuals, representative cohort of the population, how well they complied with the recommendation of the Department of Health. For men, it turned out 39% thought they did, but for women, it was 29%. They then went on to measure their compliance by fitting them up with accelerometers. For men, the figure was really 6%, and for women, 4%. They all did much better, much worse than they thought. And this is due to a phenomenon known as social desirability bias. We're all fatter than we think we are. We take less exercise than we think we are. We are less fit than we think we are, and we eat quite a lot more than we think we do. Again, how much do we do in reality? This is a graph of percentage of people meeting the physical activity guideline. It's a different guideline by then, it was 2016, with increasing age. And we find that we carry on taking much the same sort of levels of exercise in most of our adult life until we get to about 60, 65, and then we drop off badly. At a time of life when we're retiring and we need to be taking more exercise, we've got more time to do it, and the curve should go up there, it goes down, which is a great shame. We should be doing more about that, and it would take political willpower to do it. few suggestions about what sort of exercise you take. Well, housework's exercise, isn't it? Particularly if you're lifting the Hoover up and down the stairs twice a day. Gardening, walking, swimming, dancing, going to the gym, golf, indoor bicycling, home exercise circuit, playing tennis. There are lots, and it doesn't matter what you do. The important thing is that you do it, and you're not going to do it if you don't enjoy it. So wide selection of choices is what we need. So that's what I had to tell you, that it is really important to keep up your exercise level for yourself and your patients, to maintain your activity, to reduce dependency in old age, and to live longer. And this was recognised back in 1799 when a physician called Easton said, "It is not to the rich and great, not to those who depend on medicine who become old, but such as use much exercise, for an idler never attains a remarkable old age." And I'm going to finish with a small advert. If you want a book list, try Get Off the Couch Before It's Too Late by me. And if you want something rather more sophisticated, this is a textbook of exercise written by myself and David Brody. But if you just want to read about things, read my blog. I produce a new blog every fortnight. I've been doing a weekly blog for about 4 years now, but I cut it to fortnightly. Go to cardiac-rehab.co.uk/blog and read all about it. Thank you very much indeed.
Thank you, Hugh, for your excellent presentation, and thank you, Hamish. So we have 12 minutes for questions. I've noticed that Hamish has answered a couple of questions on the Q&A function, but I want to make sure that everybody has seen those. So I'm going to ask the questions again and ask Hamish if he would to answer them for everybody. So the first question is, do you have any comment on learned helplessness in deprived areas and the influence of epigenetics, thinking about Sir Harry Burns's views?
Yeah, thanks a lot. Great question, and I think there's a lot to say about that kind of thing, those two things. I think what I was getting at with lower expectations is closely related to, I think, what you mean about learned helplessness in more deprived areas, with that being more lower expectations for good health outcomes or for having healthy ways of living in more deprived areas. But I think, yeah, we have a duty to try and raise expectations. If we can influence people and raise their expectations for what is a long and healthy life, that we can do that. And regarding epigenetics, so my interpretation of your question is around how environment influences your DNA and therefore maybe your behavior. And I think we've got a duty to try and make the environment more conducive to healthy living. And if health professionals, if we can use or generate a unified voice around making healthier environments, then we need to do that, because at the moment we've got unhealthy corporations who sell harmful products, who are profiting from those unhealthy products, and we need to legislate and regulate those industries. Yeah.
Thanks, Hamish. And another one, just to remind everyone, Hamish has to finish promptly tonight. So another one for Hamish. In parts of deprived areas of England, the introduction of group consultations has reached folk previously thought to be unreachable. Has Deep End considered this?
Yeah, so I am aware of some GP practices in more deprived areas in Scotland who use group consultations for different reasons. So I'm thinking of a diabetes group in a more deprived area, and they use that group in order to reach other people within their practice population who I know otherwise may not attend the GP practice, for example. So I know that it is used, but I think, yeah, it's a really great idea and probably very helpful for research, especially.
Thanks, Hamish. So a question for Hugh. Hugh, could you pop your camera on, please, if you're still there, just so everyone can see you? Yep, fantastic. You're still there. Hugh, have you noted any difference between male and female attendance rates at cardiac rehab programs? And if so, why might that be? We can't hear you, Hugh. You're
Can you
not
hear
on
me
mute.
now? Can you hear me?
Yes, go ahead.
Right,
Yeah.
I'm sorry, I have to get very clear. I got a bad microphone on this computer, so my apologies for you just seeing my nose. Yeah, I mean, in the early days, we did concentrate more on men, and indeed, of course, we were much more ageist in those days, and there weren't too many women in the sort of age groups that we were concentrating on. Nowadays, I would say probably that the women and the men are very equal in their attendance rates, and in our Stay Well program, we have a very good attendance from both genders. I can't give you the figures of that at the moment, but the benefit of coming to us is they don't have to wear lycra, and both the men and the women, they like that a lot.
Of course, yes. And another one for you, Hugh. I guess it's more a comment than a question, but it'd be nice to hear your view on this. And the comment was that you can't exercise your way out of a bad diet. So everybody would recognize the importance of exercise, but possibly not in isolation. How would you comment on that?
Yes, I know nothing about that, and I never comment on it, and I never give advice about it. I personally, sorry, I have to confess this, I have rather an unhealthy diet. I'm sure it's right that in ideal circumstances, you'll get people to eat healthily as well as to take the exercise. The combination must be the right course to follow.
Okay, thanks. And back to you, Hamish, if I could. Do you have any tips for encouraging patients in more deprived areas to exercise? And maybe one for you as well, also, Hugh. But I guess also, to eat healthily, to abstain or to reduce harmful substances and so on. So just general comments around how to encourage people to live healthier lifestyles, I guess. Yeah, Hamish first.
Yeah, yeah, great question. I know our community links workers or social prescribers in our practice do a great job with limited resources. I think exploring what people are prepared to do is key initially, really delving deep into what people's lives are like, because you need to meet people where they're at, and giving them unrealistic advice is not going to help them, may even disrupt your rapport, or may make them less likely to listen to you. So really understanding what's feasible and building from a low baseline. Often in more deprived areas, people may be coming from a particularly low level of healthy living, if you like to think of it like that. So yeah, trying to meet people where they're at and starting from there.
Mm-hmm. And Hugh, same question.
But what strict pony, I really only do know about and promote exercise. And we do that in a number of different ways, apart from providing a program. And we do try and get the more deprived people involved by having, we run our charity does depend upon having some income from the exercises, but we do have a special rate for people who have financial problems. I've quite forgotten my train of thought, but it'll come back in a moment. The other thing I think is important is to give people as wide a choice of exercise as possible. I don't think it matters at all what they do. What we've done locally is to produce a directory of all the physical exercise, physical activity and exercise facilities in the area that we live in, and put that online and produce a booklet which is widely distributed to the GP surgeries, the library, the community centre and places like that. It doesn't matter what people do, but if they don't like what they do, they won't carry on doing it. They need a big range of choices, and I'm sure that the sort of choices that people have will also depend to a great extent on their socio-economic status, because some exercises are quite expensive.
Mm-hmm. And along the same train of thought, Hugh, have you found it difficult talking to your patients who are post-operative or post heart attack, whatever it might be, addressing their anxieties about exercise? How easy have you found it to encourage them to come to your programs and to stick with your programs?
The best reassurance you give people about exercise is to exercise test them. And many people will leave the exercise testing room greatly relieved to know that was, even though they worked quite hard, actually they came to no harm from it.
Excellent, thanks. I guess a question to both of you, really. This is a potentially a huge question. Hospitals can be danger zones, causing sedentary behavior and very poor diet often. Are there any solutions out there?
Don't send them in. Keep them at home as long as the two things you probably do need to go into hospital for, and hopefully for a short period as possible, and it's much shorter these days than it used to be, is after a heart attack or after a stroke. They need urgent treatment. Otherwise, most things can wait. If you wait a while, maybe it's not necessary.
I don't know if you want to add something to that, Hamish.
Yeah, I think that's right. Although I know hospitals are struggling at the moment to do a lot of the basic stuff. Yeah, maybe for the future, but I definitely agree that what's provided in hospitals and what's available in hospitals could be a lot better.
Excellent, thank you. Well, we have no more questions, and actually timing is just about perfect. So I'd like to thank Hugh and Hamish for their excellent presentations. I'd like to thank everybody who's participated in this evening's session, and particularly the questions that were asked. Thank you very much for that. These presentations will be available, obviously, online through the BSLM website. So please do check out this and previous webinars, and we hope to see you next month. So once again, thanks, Hamish, and thanks, Hugh, for some very interesting presentations.
Thank you very much.
Thank you very much for having us.